So moving on from reflux, the next topic that I wanted to address was the role of screening or surveillance in patients with gastric intestinal metaplasia. So the background to this is that gastric intestinal metaplasia is actually a common lesion and it is recognized to be pre-malignant. The American Society of Gastrointestinal Endoscopy recommends surveillance of gastric intestinal metaplasia, or GIM, with topographic mapping only in high-risk patients, but there are no prospective studies to evaluate the yield of topographic mapping in patients generally with gastric intestinal metaplasia. And so the aim of this study was to evaluate the use of topographic mapping for cancer surveillance in patients with gastric intestinal metaplasia. This was a single-center study enrolling consecutive adults who were identified on endoscopy as having gastric intestinal metaplasia. A detailed demographic history was taken, and topographic mapping with multiple biopsies was conducted at baseline after identification of gastric intestinal metaplasia, at 6 months after initial topographic mapping, and then every 2 years afterwards, provided that there was no evidence of dysplasia or malignancy. In following these patients up, they identified 183 patients, predominantly Caucasian, with some African Americans and Asians. They conducted a total of 276 topographic mapping procedures, which was an average of about 2.5 per patient, and they followed these patients up for about 4 years on average. Initially, incomplete metaplasia was identified in about 45%, and 40% of patients had Helicobacter pylori infection, which was treated with eradication therapy. At the initial endoscopy, 3 patients had dysplasia, 1 was low grade and 2 were high grade. And then in follow-up, a total of 2 patients were identified with low grade dysplasia and 1 patient with gastric adenocarcinoma during the average of 4 years of follow-up. Interestingly also, about 20% of patients had evidence of resolution of their gastric intestinal metaplasia. So they concluded that in a prospective cohort study, the prevalence of gastric cancer and dysplasia in gastric intestinal metaplasia is significantly lower than in previous retrospective studies. And in fact, gastric cancer was found in only about 1 per 700 patient years follow-up, and low-grade dysplasia in about 1 in 350 patient years of follow-up. So they say that gastric intestinal metaplasia surveillance with topographic mapping in a US population has a low clinical yield even in higher risk patients. And so trying to put this in context, there was a recent consensus conference which said that for patients with mild to moderate atrophy or intestinal metaplasia, particularly restricted to the antrum, there is no evidence to recommend surveillance. And a Cochrane review said that there were no randomized data on surveillance for gastric intestinal metaplasia, and that a randomized controlled trial would be desirable, although difficult. And I think the summary for us in practice is that the risk of cancer in gastric intestinal metaplasia is actually very low, and therefore in the absence of dysplasia at initial endoscopy, gastric intestinal metaplasia does not require surveillance. Moving on to the next topic of upper gastrointestinal tract bleeding, I wanted to look at a couple of abstracts, one of which looks at proton pump inhibitor therapy, and the other one looks at the role of anticoagulation. So if we look at proton pump inhibitors, upper gastrointestinal tract bleeding is a frequent cause of hospital admission and is most commonly treated with proton pump inhibitors. However, there is some variability in the treatment regimen. Some patients will have an IV bolus followed by an IV infusion, and other patients will have episodic IV PPIs. Both strategies have been studied, but the results are mixed with respect to patient outcomes. And so this is a review, a systematic review of the outcomes related to low versus high dose PPI therapy with respect to rebleeding, mortality, and the need for surgery, based on an extensive literature review using Medline and the Cochrane databases. And there was a meta-analysis performed using odds ratios and a fixed effect model. The authors found 17 studies that included the appropriate inclusion criteria. And in summary, what they found, as you can see from this table, is that there was no difference with respect to the odds ratios for outcomes with respect to rebleeding, need for surgery, or mortality when comparing high-dose versus low-dose PPI therapy. And their conclusion, therefore, is that high-dose PPI therapy in patients with upper GI bleeding was not superior to non-high-dose episodic PPI therapy. And in fact, the treatment outcomes were comparable for all three outcomes that they chose. One of the other contentious areas in the management of GI bleeding is what to do for patients who are receiving anticoagulants, and that's the subject of the next abstract. As background, the authors said that there are limited data on the safety of stopping anticoagulants in gastrointestinal bleed patients. There are some retrospective data to suggest an increased risk of thromboembolism if anticoagulants are stopped, but the optimal management is unclear, and the aim of this study, therefore, was to evaluate prospectively whether anticoagulation cessation for gastrointestinal tract bleeding was associated with thromboembolic complications. Now, this was, again, a single-center study in an academic center over a one-year period in which patients admitted with systemic anticoagulation for a gastrointestinal tract bleed were evaluated in hospital and then followed up 6 and 12 weeks after discharge with respect to the risk of rebleed and the risk of thromboembolic events. Testing was done with univariate and multivariate analysis to identify risk factors. And in brief, the results show that they identified nearly 200 patients with gastrointestinal tract bleeding, upper and lower, receiving anticoagulation, and that on discharge, about 40% had discontinued anticoagulation, whereas 61% resumed anticoagulation. And what they found was that patients who discontinued anticoagulation were less likely to have a prosthetic valve. They were less likely to have had a prior CVA or TIA, and interestingly, less likely to have had a prior gastrointestinal bleed. With respect to the outcomes, the major outcome of interest, highlighted here in red, is that major thrombotic episodes were significantly more likely in patients who had their anticoagulation discontinued, and that all of the other outcomes related to recurrent bleeding and mortality were actually comparable between the groups. So in conclusion, they say that restarting anticoagulation at discharge after gastrointestinal tract bleeding is associated with decreased thromboembolic events and no significant increased risk of recurrent bleeding. And they say that the benefits of continuing anticoagulation at discharge may therefore outweigh the risks of recurrent GI tract bleeding. So to put this in context, in relation to the recent upper GI bleeding guidelines published by Alan Barkin, the consensus statement published in 2010 said that IV bolus therapy followed by continuous infusion PPI therapy should be used for high-risk stigmata after successful endoscopic therapy. My comment on this is that the optimal PPI strategy remains unclear, but requires appropriate risk stratification and non-pharmacological management, that is, endoscopic therapy. The other statement that I wanted to pick out is that low-dose ASA therapy should be restarted as soon as the risk for cardiovascular complication is thought to outweigh the risk for rebleeding. And I think to this statement we can add the commentary that anticoagulation should also be restarted as soon as the acute rebleeding risk diminishes in patients who have been admitted with anticoagulants whilst having an upper or lower GI tract bleed. So the final abstract that I want to look at relates to Helicobacter pylori infection and the cost-effectiveness of non-invasive active tests of infection. The background to this is that treatment failure for Helicobacter pylori eradication is about 20% due to poor patient compliance and increased antibiotic resistance. And the aim of these studies and in the poster that I'm going to highlight was to assess the cost effectiveness of universal post-treatment monitoring of Helicobacter pylori infection using either urea breath test or fecal antigen test in adults. Now, as background, antibiotic resistance remains a major challenge and an increasing challenge, and there were 2 abstracts at ACG that highlighted this. In Detroit, the prevalence of clarithromycin resistance has increased to about 25%, with metronidazole at about 25%, and minimal resistance to amoxicillin and tetracycline. And these data mirror data from Qatar, for example, in the Middle East, which again shows high rates for clarithromycin and metronidazole and low rates for amoxicillin and tetracycline. Now, in the study that I wanted to highlight, they made a decision tree model to evaluate cost effectiveness, and they looked at testing after an initial course of triple therapy with repeat eradication therapy for patients who are positive. And they calculated excess lifetime costs per patient, quality-adjusted life years, and incremental cost-effectiveness ratios. For the model where they assumed full compliance with urea breath testing and fecal antigen testing, they found that the costs of the 2 tests were broadly comparable, but urea breath testing cost rather more, that the excess lifetime cost per patient was actually comparable for urea breath testing and fecal antigen testing, that the quality-adjusted life years were comparable, and that the incremental cost-effectiveness ratio therefore slightly favored the fecal antigen test. However, compliance with the fecal antigen test is less than that for the urea breath test, and when they adjusted for this, they found differences in the cost per treated patient, the excess lifetime cost, and the quality-adjusted life years that meant that the incremental cost-effectiveness ratio now suggested that urea breath testing was a cost-effective way of evaluating treatment efficacy in patients who had eradication therapy for Helicobacter. So the conclusion from their point of view was that universal retesting after HP eradication using active, non-invasive tests is cost-effective compared with no retesting, and that retesting using urea breath test is more cost-effective than using fecal antigen testing after adjusting for patient test compliance, but that the urea breath test was not dominant over fecal antigen testing. And so I think if we look at this from a Canadian context, we have to say that H. pylori antibiotic resistance is increasing. H. pylori eradication rates are falling. And in Canada, antibiotic testing is not routinely available, and tests of active infection are not uniformly available. We need therefore to consider that testing for eradication is cost-effective, but is affected by patient compliance. And I think in Canada, there is a need for a nationally endorsed strategy on testing for eradication and targeted testing for antibiotic resistance.